Dr. Rishi Mohan will be talking about corneal biomechanics as he has to go somewhere. So we'll have his talk next.
अभी ठीक है but ऋषि now wants to come first. He has to go. वो FPS का.
I would be happy to take any questions till Dr. Rishi Mohan is getting underway. How many plan to buy the iTrace after this talk?
iTrace is a beautiful device. You use it for all your cataract patients now, without exception, or only for the premium?
Sir, although it puts a lot of load on the cornea lab to be doing it for each and every person, but especially for all premium IOL patients, now we are putting in a lot of enhanced monofocal lenses and all that. That's a must, I think, and actually it should be done for every cataract patient, no doubt. Every refractive patient definitely gets it done.
So I think what is probably going to happen with time is that these technologies are going to gradually become what we call standard of care. It will take a while before devices like the iTrace or even devices like what I'm going to speak of on corneal biomechanics will find their way into every clinic. But we can already see how OCT has penetrated into a deeper segment and how the Scheimpflug based systems will also come in. So I think it's a healthy trend in that sense.
Correct.
So are there any questions for?
So we can take them in the end.
All right, then shall I
yes,
proceed?
yes, sir. Yes, sir.
So thank you very much, Dr. Amit, to invite me to this course, and I thank the AIOC for this opportunity. So I'm going to speak about a subject that I've actually spoken of for the last, 10, 15 years now, and trying to build up the understanding of corneal biomechanics amongst the ophthalmologists and how important it has become. And actually, if you look at corneal biomechanics, it actually, during our residencies, we all heard about the outflow facility and we heard about scleral rigidity. However, we never had a very good means or a technology which could actually capture it. So the tonometry studies done 40, 50 years ago were really the base for the production of these equipments. So these have now gained importance because of the advent of refractive surgery and the complications that arose out of it, namely ectasia. And it is impossible still to measure corneal properties such as hyperelasticity, hysteresis and viscoelasticity in vivo, but these instruments at least are a step in that direction. And it's possible to better plan refractive procedures that result in these unexpected aberrations, and it also possesses the ability to eliminate the effect of corneal stiffness on intraocular pressure measurements, and I'll elaborate this as we go on. So it's important to understand what we mean when we use the term viscoelastic. So basically, think of a shock absorber. A shock absorber contains two components really, a component in which there is a spring, and there's another component in which there is a gas or a fluid-filled viscous container in which a piston kind of thing goes in. Now these two have different components to how they handle tension and pressures. So the spring is what we call an elastic part of the system, where the deformation, or when you pull or push a spring, it is directly proportional to the stress that you apply. So if you apply more force, you'll get more deformation. You apply less force, you'll get less deformation. And this is independent of the length of time at which you apply it or the rate at which you apply it. So the rate of application of force or the length of time at which you apply it is not relevant to the amount of deformation that you will produce. On the other hand, viscous resistance or damping, which is the shock absorbing effect, is directly dependent on the speed with which it is applied. So the harder you try and push a piston, or the faster you try and push a piston into this cylinder filled with gas, the more resistance you're going to encounter. So this is the combination of viscous damping and elastic properties that creates the unique structure of the cornea and the sclera. Now let's talk about the Goldman tonometer. Fantastic device, but it makes static adjustments or static assessments. So what does it do? It takes the cornea and it applanates it. Then it gets into a steady state. And when it's in a steady state, it takes a reading. This derives the intraocular pressure. But the ocular response analyzer, which is the instrument I have largely worked with, and now the Corvis ST, which is the newer kid on the block, these make dynamic measurements. So what do? They throw an air puff like a standard non-contact tonometer. However, they are monitoring the movement of the cornea throughout the length of the air puff. And this dynamic measurement allows the possibility to capture the data. So this is what happens with a standard conventional non-contact tonometer. A force hits the air pulse hits the cornea, and as the air pulse increases, it reaches applanation. And the moment it reaches applanation, the machine shuts off. That's what standard NCTs do. And at the point of applanation, whatever was the force being implanted or imparted to the cornea is measured as the pressure, same like a Goldman tonometer. However, with this instrument, I'll come to this graph later, if you look at the charts at the bottom, you will realize that this air puff first creates an initial applanation pressure where the flattening happens, but then this continues to create a concavity in the cornea, and then it starts to come down, and when it starts to come down, there is a second applanation that happens on the out phase of the corneal pressure, and this creates applanation pressure too. And then, of course, the cornea comes back to its normal convex shape, but in this process, the cornea also shows some rebound or flutter, and because it's a viscoelastic equipment, so that entire thing is monitored by these machines, and lots of data is able to derive from it. But broadly speaking, the single most important data that one gets is the difference between applanation pressure 1 and applanation pressure 2, and this is called corneal hysteresis. So studies have concluded that the variation in corneal thickness affects the accuracy of the measured pressure. However, the over or underestimation of pressure caused by corneal interference is only valid on average, and the relationship is not very significant. And if you talk to glaucoma opinion leaders, they'll tell you that adjusting intraocular pressures just by using a thickness-based algorithm is essentially flawed because of the fact that the thickness and the viscoelastic properties of the cornea don't correlate. So look at this. This is the corneal hysteresis and the corneal thickness. The R value is 0.27. So you can see that the corneal thickness can vary from 450 microns to 650 microns, and the scatter of the amount of hysteresis that is there is all over the place. So there is no distinct correlate between thickness and the way this cornea actually behaves when you try and subject it to any pressure. And this is the problem with these these CCT-based IOP adjustments. So you imagine a piece of pine wood, and you try and put a force in it to bend it, and then you do the same thing with the same thickness of oak wood, and you'll realize that the same force does not cause any distortion at all. So thickness is not resistance. And this is what happens in people with normal tension glaucoma. Are these patients really normal tension? They have glaucoma, but do they have a normal tension? The answer to that is they probably don't. They're probably glaucomas with a high pressure, but they are being missed because the machine is giving you a normal tension. And that is why machines that allow you to give what we call an IOP-CC. IOP-CC stands for intraocular pressure corrected for cornea. And IOP-G is intraocular pressure by Goldman. And this is the kind of graph that you will see. All these patients of NTG were actually, actual pressures were much higher when the IOP-CCs were measured rather than when IOP-G. So IOP-CC measures higher than current tonometers in NTG eyes. Again, in post-LASIK, we've thinned these corneas. What happens to your Goldman pressures? They drop. On average, they will drop 26%. But if you look at the IOP-CCs, they only drop 3%. That's because they are not looking at the thickness at all. They're looking at the biomechanics of this machine. So the IOP-CC and Goldman on average will correlate, but will not be affected by CCT and will not be affected by corneal biomechanical properties, and therefore is far more accurate in keratoconus, in Fuchs, in ocular hypertension, in normal tension glaucoma, and it has much less influence by doing a post-refractive procedure, and there is of course no operator bias. So thickness, as I said, is not strength, and that is the problem with refractive surgery. We look at thickness, we have this PTA formula, and we have a formula of residual stromal bed. All these are flawed, essentially because they may be soft corneas, which may require larger residual beds, and that's why you hear of the patients who followed all the norms and still went into ectasia. And those which may have hard corneas, and we all have experience with patients who we, in the earlier days, did very high numbers of ablations and still got away with it because they can take these aggressive ablations more safely. So the pre and post LASIK, if you look at the hysteresis values, you'll find that there is the average pre-LASIK population has a higher hysteresis than the post LASIK population because of the thinning that has been produced. But there may be the outlier, and that's the patient that you need to look out for because he's the one who's prone to develop ectasia. Similarly, when you classify corneal pathologies, you have patients with keratoconus on one hand, which are thin corneas, and you have patients with Fuchs dystrophy who have thick corneas. So the thickness can vary by 100 microns, but they all have less than normal hysteresis. So thickness doesn't necessarily relate to how the cornea actually behaves biomechanically. And these are some of the analysis of the normal signals from these machines, where those who are familiar with these signals will immediately know what I'm talking about. These are nice similar signal amplitudes of the first graph that I showed you, the applanation in and the applanation out. The CH and the CRF, as well as the IOPG and IOPCC are in the normal range. But when you look at keratoconus, you see blunting, you see a noisier signal, you see lower amplitude in the peaks, which are sharper and thinner, and you get a bounce because of the flutter of the cornea as it settles down. It doesn't just settle down like a rigid structure, it flutters as it settles down, and that's what is picked up by these equipments. So subclinical keratoconus again has been classified by these machines. Severe keratoconus, look at this. The cornea is so soft that when the corneal pressure, when the air puff hits, the whole cornea just flattens, and that's why there is hardly any result or any signal coming back from the cornea. So pre and post LASIK signals similarly are very similar, but the IOPCC is higher than the IOPG, again because of the fact that the cornea has been thinned, and there is the little bit of noise and P2 bounce. Ectasia starts to behave like keratoconus. So if you have a patient of ectasia and you're not sure, put him onto one of these ORA machines and it'll give you a diagnosis immediately. So there's another part of this thing called the keratoconus match index, wherein one can put the patient on this machine, and based on the corneal biomechanical values, it can suggest what is the possibility that this patient has keratoconus. So this patient, for example, 89% chances are he's normal. This patient, only 34% chances he's normal, 53% chances are that he's a suspect. And this patient has mild keratoconus, possibly 26% chance he has a moderate keratoconus. So these are the kind of things that are there. Post cross-linking, a little bit of improvement is seen, which is not dramatic. So the signals are the corneal signature in this machine, and that is something that is of great value. And these are the clinical applications for corneal biomechanics in pathology diagnosis, ectasia screening, post-LASIK IOP measurement, much better to check the post-op corneal stability and wound healing, the glaucoma diagnosis, normal tension glaucomas and ocular hypertension sleevings, and also glaucoma treatment efficacy. The latest kid on the block, the last couple of slides, is the Corvus ST. And now the beauty of this machine is that it has now been clubbed with the Pentacam. So you can now get a combination of the two, which gives you topographic values, thickness values, and now biomechanic values, and they've all been clubbed together to make it easier for people like me to understand. So this again works on the similar principle, except that instead of optical assessment devices, it actually has a Scheimpflug camera and can give you a video of that corneal fluttering as what I explained to you in the beginning. And then it also gives you a biomechanically corrected IOP, which is called the BIOP, similar to the IOPCC that I spoke of. It gives you a biomechanical index, and it gives you, with the tomography, if you club them together, something called the tomographic biomechanical index and the biomechanical glaucoma factor as well. So these are some of the new things that have come out. And just to highlight a patient who was finally changed in terms of what we were planning to do, was a patient who had moderate myopia, normal Ks, not a very thin cornea. An initial plan was to do a femtoLASIK, but then after looking at the biomechanics and looking at this, and you can see at the bottom there, the circle where that line is in the red zone. So the tomographic biomechanical index of this patient wasn't very good. So he was taken off the LASIK list, put onto a PRK, and also an extra procedure, which means the CXL was done simultaneously. So to summarize, the biomechanics assessment is now a major investigational modality. Ectasia detection and filling the missing link in the screening is important for high-risk refractive surgery cases. It assists proper IOP evaluation and the detection and management of LTG. And tonometers equipped with biomechanical adjustment algorithms are more accurate in diseased corneas and in post-refractive cases. And they allow in vivo measurements of corneal biomechanics can be used to assess the efficacy of corneal cross-linking and corneal healing. So thank you so much. I'll be very happy to take any questions. Thanks, Amit.
Thank you so much, Dr. Rishi. Dr. Rishi Mohan has, very nicely brought forth the role of corneal biomechanics. A lot of us are reluctant to do it. We do not really want. I have one question for Dr. Rishi, that we do it in so many patients before refractive surgery. And do you repeat it after refractive surgery in these patients? And if so, after how long in patients who have had thin corneas, they've undergone LASIK, just as to record something that, that, okay, fine, this is how it was.
No, actually, that would, I think in busy practices, people would hardly do that. So if it's an uncomplicated refractive surgery, he's had no problems, he's doing well, we wouldn't ordinarily put him back on this unless we suspect that his IOP was borderline, or if he has a large disc, or if he was a very high myope, and you still want to see what his corrected pressures are, because his pressures will, like I said, substantially drop if you put him on an applanation tonometer or if you have a conventional NCT, because the conventional NCTs are all calibrated according to IOP Goldman. They are not looking at corneal biomechanics at all. And so 90% of the tonometers which are currently out there are not catering to that. So that where this scores hugely.
So any questions from the panel?